এটা একটা just we termed it an UCD Study Circle. Initially, we started it with 3 senior members, myself, Shoumitra and Shouro, and all the pass outs of medical college, DM pass outs of medical college till date. There are 25 of them. I talked to everybody personally and invited, and everybody agreed to join. Due to some reason or other, a few may not be able to join every day, but all are members, and we may increase this number of the study circle depending on the response. Those final year batch students or DM students of medical college and some of the past students of mine, those who has passed MD from medical college and did their SRship under me. There's some very close group. It will be a very close group, so that in addition to and the academic affairs, we will have an interest of meeting each other at least virtually. So these two are the basic objectives to keep us updated. Myself, Soumitra, Shouro, all of us are not in direct contact, I would rather say. We do some academic activities, but that is of our own. We are not in any structured academic frame. Unfortunately, Shouro is in a place where there is no DM. That is his handicap. Myself, I have already retired. Shoumitra is again, he has left his job from Ramakrishna Mission, and he is again of his own. So it is for our mutual benefit. All of us will be updated. So the selection of the subjects will be yours. You can select a case, you can select a topic, you can select a recent guideline, you can select whatever you feel is helpful for updating all of us. So with this view, for the first session, I requested Dr. Siddhartha Mani and Dr. Bashabendra Choudhury. Siddhartha will be presenting an interesting case, and Bashabendra Choudhury will be talking on HFrEF, a particular aspect of HFrEF. All of you are eligible and you can ask questions, but at the end of the presentation, for that, I have told Jignesh, who is making this platform, to make some mechanism so that all do not talk at a time, and this can be smoothly carried on. So with that introduction, and I propose to put this all these sessions in the YouTube, so that let it be there, and we can have some good cases and some good topics. If we require any time, we can retrieve that thing from the YouTube. Fine, thank you. So with that, let me request Dr. Siddhartha Mani to present his case.
So good morning, all of you, and my sincere thanks to Sir for organizing this study circle, because the more interesting part is we will be able to see the old familiar faces, and really it's good to see all my seniors and friends and juniors in the same platform. I have not met them for so long. And the only request to Sir is the question should be directed to the junior batches, so that
that is not going to happen.
Okay, so I will be presenting interesting intervention case, and this was of a difficult retrieval of EmboShield graft, protection device during a graft PTCM. So go to the first slide. Go next, shift to the next slide. Darshan, are you there? Yeah. So this is a 70-year-old the previous one. This was a 70-year-old hypertensive non-diabetic gentleman and was complaining of exertional angina for last 1 year. Now he had a previous history of CABG in 1998 for severe triple vessel disease. And post CABG, he was doing perfectly well till 1 year before, and he was already getting all optimal medical therapy, including high dose statins, and he was on single antiplatelets while he presented to me, because it was long after the CABG. He had been shifted from dual to single antiplatelet, and during presentation, hemodynamics was more or less stable, BP was controlled, and there was unremarkable findings in the CVS or respiratory examination. The only problem was he was having angina on slight exertion. Next. Next slide.
Darshan, next slide, please.
Okay, so this was the ECG. You can see quite deep inverted and symmetric T waves in the anterolateral leads. Okay. So the ischemic changes were quite prominent in the ECG, and if anybody has any comments later, we can discuss about the ECG. Next slide. Next slide. Darshan, why the slides are taking so long? Can I control it from my part?
No.
Yes, sir, I'm pressing right now only, but I think it will take time to show at your side.
Okay, no problem. So the echocardiogram was showing concentric LVH and hypokinesia in the LAD territory. The ejection fraction was moderately reduced. It was 44%. Next slide. Okay, so now coming to the coronary angiogram, it revealed the native triple vessel disease as expected from the previous results for which the CABG was done. There was also LMCA involvement. LMCA had tubular 70% stenosis. The native LAD and LCX was totally occluded. There was a Lima to LAD supplying, Lima supplying LAD, which was normally patent. RCA had proximal tubular 99% stenosis, and the RSVG to OM graft, which was supplying the OM and retrogradely to PDA, PLV, and RCA, that RSVG graft had 80% proximal stenosis, followed by a mid 80% stenosis. So there were two tandem lesions in the prox and mid part junction, and that was the vessel which was supplying the OM, the PDA, PLV, RCA. So it was supplying a big area of the heart, and that was having significant stenosis, and probably that was the cause of angina because the Lima was perfectly patent. Next slide.
So Siddhartha, there are two grafts, Lima and
there are two grafts. There are two grafts. Yes, sir. The RCA did not have any graft.
Okay.
So just the video, run the video, Darshan. Yeah. Maybe you have to repeatedly click it, otherwise it may stop you. I don't know what software you are using. Yeah. No. Go to the previous slide. Don't shift the next slide. Yes. So you can see the graph. You can see the two tandem lesions. The proximal one looking more significant in the proximal part, and the middle one, it is also quite tight, and it has eccentric plaques, and it was ulcerated, and maybe there is a small dissection flap. You can see a small outpouching in the wall. So this was what I was aiming to intervene at, and because it was a very important vessel, obviously, as it was supplying the RCA, the right territory also. So next slide.
How was the distal runoff? Couldn't see that much of.
The distal runoff, it was not feeding the PD PLV too much. I mean, you can, the portion up to which you are seeing, that was the flow was up to that much only. It was, you can say a TIMI 2 flow hardly.
Yeah.
It was not filling the right side.
Okay. Yes. It's not going up to that.
So yeah, so I had taken the EmboShield device, which has an inbuilt wear. So I have to pass the wear of the EmboShield device first with the filtration element. Here I cannot use my choice of wire, but this wire, it is an intermediate wire. It is quite good. It is its torqueability and everything is perfect. So it went in easily. I did not have to manipulate too much. Next slide. Next slide. So the wire has gone up to the distal part into the OM, and now I was pushing the filtration element. It is customary to push the filtration element almost 10 millimeters distal to the distal most lesion, which I did here. And during pushing this filtration element, there was, I did not face any hindrance. It was smoothly going in. Next. So we all know that graft PTCA is different from native vessel PTCA in terms of its thrombotic burden, its friability of the lesions, and I would suggest that all cases of graft PTCA, if the patient can afford, you should use a distal protection device. So that is often not possible because of the financial issues, but yes, if it is possible, we should do it. So after this, the procedure was like a routine procedure. I took a 3.5 millimeter balloon, and obviously because the grafts are of more caliber, and we usually require 4 or more than 4 size stent, so we tend to use a larger size balloon as well. So we have started with a 3.5 millimeter balloon, dilated the distal and proximal lesions sequentially, no problems. It was going on smooth. Next slide. Next slide. Okay, so the first stent we took was a 4 into 37 millimeter biomime, and it had gone in smoothly up to my desired area. As I had said, that you have to keep your distal protection device at least 10 to 20 millimeters distal to the distal most point, and you can see that here. And we have kept the stent accordingly. Next slide. Next slide. Okay, now you can see that the first stent has been deployed. It is well expanded. We will show the angio run later. We'll see the angio run later. Now pushing the second stent was quite difficult. The catheter, you can see that the catheter from the very beginning was not very well placed inside the graft. It had some angulation for which the tip of the catheter was just touching at the ostium. So here I had a lot of difficulty.
Which catheter you are using, Siddhartha?
Sir?
Which catheter you are using?
GR.
GR.
Yeah, this was a GR. So usually the RSVJ grafts which arise from the right side of the wall, we prefer GR catheters if it sits well. Otherwise, sometimes maybe we have to take NTRs or some other guides sometimes. So after some manipulation, this second stent could also be passed. But you will be able to see in the next view that I could not exactly overlap the proximal stent with the distal. So there was almost a 1 to 2 strut gap between the two stents, which I had to accept because I was unable to push it any further. Next. So you can see the marker, the distal marker just going inside the stent, but it was not fully overlapped. So the second stent was deployed. Next. Next slide. Next slide. Yeah. So if you see carefully, there is a small 1 millimeter gap in between the two stents, but I think that was acceptable because I could not push it any further. There was some under expansion in the middle part of the proximal stent, so I had to try some post dilatation. Next slide. Next slide. Yes. So I post dilated across both the stents and also the overlap area with a 4 millimeter. No, you are jumping. Just yeah. Come to the previous slide. So I had done a post dilatation. You had seen with a NC balloon, 4 millimeter NC balloon across both the stents and across the overlap area. Next slide. Next slide. and there was a slow flow. Now it is very common when you are using distal protection devices. After you deploy the stent, slow flow is a common phenomena. So we were expecting a slow flow, and we thought it to be normal just because of the protection device, but still we gave our usual medications like nicorandil, intravenous GTNs, and nitroprusside, SNP. So after that, go to the next slide. Go to the next slide. Okay, so is it the one, or we have missed another slide before this? Just check. Okay, no. So there was some slow flow persisting even after the medications. So next slide. So now my job was to pull back the filtration element, but before that, it is the method is you have to push the retrieval catheter up to the proximal marker of the filtration element, keeping the filtration element exactly at the same place where you had done the procedure with, and then gradually pull back the filtration element into the retrieval catheter, and then pull out the assembly together. But while you can see that there is a marker inside my catheter. So as I was trying to push the retrieval catheter, it was not going in at all. And you can see that the filtration element has already dislodged, and the proximal marker of the filtration element is almost up to the stent margin. So now if it pulls back any further, if the filtration element dislodges any further, there is every possibility that the distal margin of the stent will get distorted. So this was a very delicate very delicate maneuvering what I had to do, but still I was unable to push it inside any of the stents. So next slide. Next slide. So I had taken different views, and I tried, after trying a lot, I thought of introducing a second coronary wire, at least up to the filtration element, which will give me some additional support. Maybe it will straighten up some tortuosity. Straighten up some tortuosity, and then maybe I could push my retrieval catheter inside. So here the same thing you can see. Go to the next slide. I just introduced a second wire up to the filtration element, and I was able to push the retrieval catheter now. Probably I had gained in some support. Just let the video run. It is a little bit longer run. So I was very delicately maneuvering everything at a time: the second wire, the first wire, the catheter, and the retrieval catheter. So finally, you can see that the tip of the retrieval catheter is touching the proximal marker of the filtration element. So this was the most important part. Now you can see that it has touched, and it is time to pull back. Next slide. Next slide. So now I could finally withdraw. You can see I am slowly withdrawing the filtration element into the retrieval catheter, although it was almost within my distal stent, but luckily I got away with this, and it did not distort the stent. Next slide. Next slide. So this was the final result. So you had seen a slow flow, which had gone after pulling back the retrieval catheter, the filtration element. You can see some under expansion, but this is common in graft PTCS. You do not get exactly smooth borders like we get in native RCS, but I think the result was quite satisfactory, and the stent was 4 mm size. So obviously there was good gain in lumen area. So that was the final result. Next slide.
What French was the retrieval catheter?
The retrieval catheter, we took a 7 French catheter, and the retrieval catheter goes inside a 7 French. So I cannot exactly tell you the millimeter measurement, but it is compatible with a 7 French guide cat.
5 or 6 maybe, yeah.
Maybe 5 or 6, yes. So the take home is graft PTCS should ideally be done under distal embolic protection device. That is very obvious. Retrieval of the filtration element usually is reasonably straightforward. It does not cause any problem, but somehow it was a problem in my case. and dislodgement can lead to distortion of the stent or even entrapment of the device. So we need to be very resourceful and cautious, and taking the help of a second coronary wire may be of some benefit, like in this case. So thank you so much. We can discuss now, sir. Up to sir.
Please stop screen sharing.
The initial
What-
slow flow after the second stent is perhaps there was some new thrombus or some gruel in that. So did you get any material in your retrieved filter?
No, we did not. We did not. Although it does not have any suction mechanism, so I mean, it does not act like a suction catheter. But yes, if what you are suggesting is on flushing the catheter, sometimes maybe some gruel materials coming out. But sir, this slow flow is really very common with distal protection, because I have done quite a few cases and I have seen this slow flow in almost every case, because of the filtration element, and probably the filtration element catches some gruel material. So that is why it gives slow flow. Until and unless you will pull it back, you won't get the flow. But it is better that keeping that you can give some intracoronary eptifibatide or the other nicorandils and all those things, because if anything is to be washed out, let it be caught by the filtration element, and after you bring it out, there should not be anything inside.
Dr. Mani, was there any clinical and echocardiographic improvement in this patient post-procedure?
Sir, immediately post-procedure, there was no significant echo improvement immediately, but the patient angina has subsided. The patient was clinically perfectly doing well. The recent most echo, I don't remember the exact percentage of the ejection fraction, whether it has improved significantly, but the patient has come for 2-3 clinical follow-ups and he is doing well. I mean, symptomatically, he is doing well.
Siddhartha, a few issues. One is, once you put in the emboscule inside, that is a mass. It catches some debris that further becomes a mass.
Yes.
It increases in caliber. So that is bound to be a slow flow. That is rather expected. The only issue is in this particular case, what I observed is that perhaps there was some kinking or something. That's why you are unable to put in the second stent as well as the retrieval device.
Yes, and you can see that the guide catheter, it was
falling down.
peculiar perpendicular angulation while it was sitting inside the ostia.
It was not a linear angulation.
Yeah, it was not coaxial. It was
not coaxial. It was rather at an angulation. So
maybe some other guide cath would have served better, but because it had I mean, it went in and it was the views and everything was perfectly okay. So I went on with that catheter only. Maybe initially I could have changed to some other catheter like multi-purpose or something.
The moment you put in the second guide wire, that perhaps the tortuosity became more straightened and everything became fell in place. What is the cost of this thing?
95,000, around 1 lakh, sir.
Supradeep, you are telling something, please?
Yeah. Any question?
Manida?
হ্যাঁ
Hello?
হ্যাঁ বল শুনতে পাচ্ছি সুপ্রতীক
Hey, English.
Hello?
This is getting recorded.
Manida?
yeah I can hear. Tell me.
Manida, probably you have taken that option because can you mention the size of the second stent? Because I think that is
It
probably
was
due
4.
to the
It was also
angulation.
4. It was also 4.
Or it was
4
4
millimeter.
into
4
into length of the stent?
I did not mention it in my slides. Probably it was 37 only. It was similar. I think
Similar.
both the
And,
sizes look similar. 4 millimeter
and
I
which
remember,
stent
but
it
the
is?
length probably it was 37.
And which stent it is? It is biamine also.
Same. Biamine, yes,
Same,
because
same.
we did
So-
not want to change the drug.
because your first stent goes quite smoothly. But in second case, probably it is the angulation of the catheter changed, and I would rather prefer in that case to put a body wire so that the angle of the catheter may change, because you don't have that options of changing guide
No,
catheter.
yeah, I get your point. I get your point. Just a second. Yeah. But what happens is once you have put in a distal protection device, you cannot put in a body wire across that distal protection device. You don't have that option because you cannot make a wire pass through those filters. So the maximum you can do is,
distal.
yeah, the maximum you can do is you can put in a second catheter up to that filtration element, which ultimately I did while retrieving. But you
yes,
cannot pass a catheter up to the distal bed of the vessel.
Dr. Rothin Karmakar, you have said something?
First of all, it's a nice case, Mani. It's a difficult one, but I just want to make one comment regarding the second stent, as Supit was highlighting. Did you try with the lower length? Some the length of the second stent could be made a little bit lower. In case the first ones are not going, as I can see the
Yes. Obviously, that is obviously a well taken suggestion. If it does not go, maybe a smaller size, a shorter stent would have passed easily. But I did not face too much of a hurdle in pushing the second stent. Yes, it was some. I mean, there was some difficulty, but with slight manipulation, I could push it. Just there was a 1 millimeter gap in between the two stents, which I thought it is acceptable, because the minimum margin you require for in-stent restenosis or peristent restenosis, that is slightly more. I mean, if you leave a gap of 4 or 5 millimeters in between the two stents, then the chance of restenosis in that peristent area is high. But if there is only a 1 millimeter or a 2 millimeter gap max to max, it is almost like the gap in between the struts. So it does not cause too much of a chance of restenosis. So that is why I took that risk. Otherwise, I would have preferred to go into that stent and overlapped it at least by a few millimeters.
Another it's a critical one. You mentioned in your echocardiogram finding that the wall motion abnormality was in the LAD territory, but on angiogram you found somewhere else. The problem was somewhere else. So how can you make this?
Probably
what
happens is, yes, I get your point. Probably during the initial event in long back in before CABG, maybe at that time the patient had an anterior wall infarct. And at that time, they found an LAD, occluded LAD and left main disease. So maybe from that time only, the LAD area was akinetic or scarred. And they have put in a lima because they had done an RSVG to that part. So they have opened the chest, they have put in a lima. They did not go for a viability of the LAD territory and all those. So now this time he is presenting with the angina. So maybe because of this side.
I've got 3 very short comments, Mani. Number one is the ECG,
yes.
And you said there is a concentric LVH. It looked like there an element formifrusty of hypertrophic cardiomyopathy.
Yeah, the ECG is quite typical. ECG is quite typical.
But that part is there in V2, V3, particularly the
Up
which
to
is
V6,
very similar.
Exactly.
You may follow up this
V6.
patient. You may follow up this patient. There could be an element of HCM.
What is the age of the patient?
Number 2 comment
it
is
was
that
70 years, sir. So it is hardly any time left.
It's
for
a formifrusty. I think it's a formifrusty, perhaps. Number 2 comment is that, is there any scope of mother and child technique to get the retrieval catheter? Do the size permit? Because
No, I get your point. So for that, I mean, the guidezilla or something, if you are telling that if you can push the retrieval catheter inside the guidezilla, so that is not possible. One thing you can try, I have never tried, it's just my hypothetical speculation, that if instead of the retrieval catheter, if you can push in, in extreme cases, you can push in the guidezilla up to the filtration element, and if you can pull it back, if it somehow gets entrapped or something. So maybe that is a possibility, but it is very unscientific. I mean, the retrieval catheter is perfectly made for pulling it in. So it should not be practiced.
And my last comment is that, as Dr. Shantanu also said, you are also saying that distal filtration often produce some slow flow, but that slow flow should be distally. Here, your slow flow was at the level of the proximal stent.
No, sir. Even
Proximal
sir,
stent, there was hardly any flow.
no,
That
I
is
understand.
not explained by the filter.
No, sir. It is explained because, see, if there is a stagnation of blood or a slow flow, that means a stagnation of blood or flow in the distal part or in the mid part, there is obvious stagnation in the proximal part also. I mean, the slowing starts from the proximal part.
Backlash effect.
Backlash effect.
Does high pressure saline injection helps?
For slow flow?
Just to get those things mechanically
No,
out.
sir. Why should you use that? I mean, it has chance
block.
of dislodging your thrombus through the, I mean, micro thrombus through the filtration, because we know, I mean, by using few cases, we have seen that this slow flow is common. So we will never try such high flush. So
it can, by dislodging, it can even clog the microcirculation and produce a permanent sort of a thing. That remains a probability.
Yes. If it is some thrombus or something causing, I mean, slow flow, so you pull back the filtration element and then you try other therapies which we do for our usual no cases. Yes.
Any
Good
other
case.
question? Good, very good case. Any
Very good
question?
case. Very good.
Ovik, Shomnath, Rajorshi.
Siddhartha, you must have searched the literature before presenting this case. So what is your experience from the world literature regarding this particular predicament?
This retrieve, I mean, this difficulty in pulling back the filtration element. It is not very common, sir. It is usually, that is why I mentioned in my take-home message, it is usually straightforward. I don't know why it happened, because once you have put in the stents, the stenosis has gone, the caliber has increased, and usually it is difficult to push in. It is not difficult to pull in. But maybe because of, as everybody is mentioning, that there is an angulation of the guide cap, and after I have put in the stent, maybe I have somehow changed the anatomy or tortuosity of the graft. So now the angulation it is creating, maybe because of that I am not being able to push in my catheter. So this is quite a, I mean, very interesting case. So in last year TCTAP also they accepted this case wholeheartedly. So it is not very common.
Maybe also the design of the stent also. Maybe there was some you didn't do the ultrasound or OCT or anything.
No.
So maybe there was some element of the stent struts which were preventing the.
No, sir. No, sir. In that case, my retrieval catheter would have entered the stent. I was not being able to push it inside my proximal stent. It was backing out.
Did you
from
go
the
up to the proximal end of the stent?
Yes, I could not enter the stent itself.
Yeah, so it could be a problem at the ostium of the stent, you know.
No, if there is a problem, so that problem is at the interface of my guide cap and the proximal end of the stent. Yes, and there is also possibility that the proximal end of the stent may be distorted because of this pull and push. Yes, there is a possibility.
That's what I'm telling you.
But I have done post dilatation, so hopefully I don't know, and the flow is not,
unlikely, right?
Because many times in simple cases we found it's very difficult to put the post dilatation balloon also after the stent deployment. I don't know why. Some distortion of the stent. I'm not very sure.
Most
the
of the
normal tortuosity of the vessel
wire
goes
bias.
away.
Even
The
the balloon
normal
does not go.
tortuosity, it changes.
Yeah.
Nice. Shomitra, you're doing a good picnic in the background. It seems you are doing a picnic. I'm getting jealous of you. Anyway.
Samosa and tea and samosa.
Good. Any question? Shupratim, you are asking something?
No, there are few case reports in carotid arteries where they
Yes.
have used that brain balloon bridge techniques or this kind of technique. In that case, they have used body wire and some 5 French soft tip guide wire. Instead of they didn't have used that guidezilla in coronary arteries. There is no case reports of retrieval in coronary arteries, but there are few case reports in carotid arteries.
Because
And
carotid artery intervention, it is mandatory to use protection device.
Protection, yeah.
So the
yes,
number of cases, the experience is much high. And the most important and the most dreadful part is, if you have ever seen an embolic protection device, you can see it is just like an IVC filter, a miniature form of the IVC filter. So it has 3-4 prongs like this proximally. So while it gets dislodged proximally, and suppose this is my distal end of the stent, so sometimes it may happen that one of the prongs, some of the prongs, they get entrapped into the vessel, in
the
between the
stent.
vessel wall and the distal stent star. So I was very much afraid of that, because you had seen that the filtration element has gone inside the stent. So I mean, it has come up to the distal end of the stent and almost 1 to 2 millimeter inside. So that would have been a very deadly situation, but somehow I got away with it.
Any other question from anybody? And may I request everybody to please open the video. We want to see your faces, man. It is not enough that you have joined. We want to see your faces.
Sweet faces.
Yeah. Any other question? Ovek, Shomnath, Bappa, Rothin, Rajarshi, Miraj. Okay, if you don't have any question, in that case, thank you, Siddhartha. Thank you very much for this nice case.
Thank you so much, sir. Shakti, nice opportunity to meet and present. Really thankful, sir.
And I'll expect you to attend the next one 2 weeks from
Absolutely,
now.
absolutely.
And,
I'll be there always.
The second presenter is Dr. Bashabendra Chaudhary. Bashab, you are here.
Yes, sir, I am here.
You want to share the screen yourself, or?
No, I have told Mr. Darshan.
Okay, fine. So your subject is evolution in pharmacological agents showing survival benefit in HFrEF, evidence-based and current concepts regarding sequence of initiation. Very interesting and up-to-date topic. Please.
So I would start by thanking sir and everyone in the organizing committee to arrange such a beautiful gathering where we can meet at least virtually all our seniors and colleagues, which has become very difficult nowadays to do. So after the interesting intervention case, I have been given the opportunity to present slightly long and I would not say difficult, but uh, involving many datas and
Controversial, rather controversial subject.
Controversy is always there.
Debatable things. Okay, yeah.
So the real debate will come up at the end. So first of all, I would go on discussing the history and the evolution, the history of the different agents which have been tried and tested for giving benefit to HFrEF patients. That means heart failure patients with reduced ejection fraction. Next slide. Next slide, please. So if you look at the previous one. Yes. If we look at the timeline of the different trials which have used various agents to show whether they are safe and efficacious in controlling the mortality, the morbidity involving the hospitalization rates and other CV events in patients of heart failure, we can see that before 1980s, the diuretics and digoxin were the only available supports. And it was in the mid 80s that different agents like vasodilators were tested, and it was after that several trials followed involving different agents. So if we can look shortly into this list of the important trials, in 86 the vasodilator therapy with hydrolazine and isosorbide dinitrate was tried in CCF patients. Then came the ACE inhibitor trials, and starting with consensus, then solved. Then came the trials with ARBs like valsartan. In between, there were trials with beta blocker like carvedilol, and then metoprolol and bisoprolol, uh, which went on to show a great benefit in improving the mortality and morbidity in heart failure patients after when they were started after the initial stabilization when patients were euvolemic. Older drugs like digoxin, however, failed to show the mortality benefit. However, symptomatic benefit was still there in RCTs like the DIG trial. Then came the MRAs in trials like RAILS and emphasis heart failure, where significant improvement in mortality were shown. And in between, some agents which were initially very promising, like milrinone or nesiritide, actually failed to show mortality benefit when they were tested in strict RCTs. However, in acute decompensated states, still in the ICUs and ITUs, they have, and especially in the cardiothoracic department, they still have their role in selected cases. Uh, Finally, in the mid 2010s, that means around 2014, uh, newer agents like sacubitril valsartan, that is ARNI, came into the foray, mainly with the help of the paradigm heart failure trial, which changed the uh, older concept of giving a SE, and which was a must before that. And as we know, in our present day, ARNI, that is sacubitril valsartan, have become a very strong player and one of the stronger pillars of heart HFrEF management. So I will go into the details of the trials shortly, without wasting much time. If we can cover the important trials, and then we will see whether which we can follow the older concept of the European Society guidelines of starting sequentially adding different agents to our HFrEF patients, or whether we should follow a newer trend which has come up over the past year. So next slide. Uh, if we look at the older trials, the oldest trial which came up in the mid 80s, the VHF trial, 642 men with impaired cardiac function who were on digoxin and diuretics, a relatively smaller trial which was significant in if we consider those times. They were tested, they were randomized to receive placebo versus prazosin versus a combination of hydrolazine and isosorbide dinitrate. Over a follow-up of after follow-up of 2.3 years, it was shown that mortality was lower in the hydrolazine isosorbide group than in the placebo group, and the prazosin group showed mortality similar to the placebo group. So this actually proved the effectiveness or the efficacy of the vasodilating agent in patients of heart failure with reduced ejection fraction. Next came the VHF2 trial with 804 patients of heart failure who were on digoxin and diuretic therapy. They were randomized to get enalapril 20 mg daily versus hydrolazine isosorbide combination. They were followed up for 2 years, and after that, it was shown that mortality was actually lower in the enalapril group than in the combination of hydrolazine and isosorbide. However, the vasodilating combination of hydrolazine and isosorbide could achieve symptomatic benefit and increase in LV function earlier within 8 weeks. Next slide. The importance of SE inhibitor in the management of HFrEF was actually proven and stamped by the consensus trial in 1987. 253 patients with severe heart failure, that means NYHA class 4 heart failure, who received placebo versus enalapril, which was titrated from a dose of 2.5 to up to 40 mg per day. And on top of conventional heart failure therapy, like vasodilators were also continued besides the trial medication. So after a follow-up of 188 days, mortality reduction, significant mortality reduction was shown in the enalapril group. The relative risk reduction was around 40% at the end of 6 months, and it was around 31% at the end of 1 year. This is a huge number, and the significant decrease in death due to progression of heart failure could be seen, but sudden cardiac death reduction was not so much. So after this, the vasodilating therapy fell out of favor a little bit, and the SE became as the first line of management for HFrEF patients on the basis of the success of this trial. Next came SOLVE treatment trial, patients with congestive heart failure, with less than EF less than 35 and less severe heart failure. That means 90% of them were in class 2 or 3 on conventional treatment. They were randomized to get placebo versus enalapril. After a follow-up of 41 months or so, the relative mortality risk reduction of 16% could be achieved with enalapril, and also there was significant reduction in hospitalization. In the solved investigator study, it was shown that in over 4,000 patients with asymptomatic LV dysfunction with EF less than 35, but they were not symptomatic with heart failure. It was shown that overall mortality or CV death reduction with enalapril was less, but it was not statistically significant. However, the development of heart failure and death in the study period could be reduced. So this gave rise to the concept that we can use SE inhibitors in asymptomatic LV dysfunction as well to gain the benefit of reduction in the incidence of heart failure and death due to heart failure, though overall mortality may not be reduced significantly. Next slide. Around a decade later came the ARBs, which had the advantage of the pharmacologic advantage of directly binding to the receptors and inhibiting their action rather than inhibiting the enzymatic pathway. As a result, the allergic reactions, the cough, the angioedema incidence was less with this agent. However, if you look at the trials, actual mortality benefit in HFrEF patients with the use of ARBs, overall mortality reduction has not been yet proven. So if you look at the VALHEF trial, over 5,000 patients with heart failure of various classes, NYHA 2 to 4, 160 mg valsartan versus placebo twice daily on top of the prescribed treatment was tried, which included an SE inhibitor in some of the patients as well. The results showed that there was significant reduction in the combined endpoint of mortality and morbidity, and there was also improvement in clinical signs and symptoms. And in the group of patients who received a combination of valsartan, SE inhibitor, and beta blocker, actually the incidence of mortality and morbidity was more. So led to the concept that we should not use the SE inhibitors and ARBs together. We can also look at the CHARM alternative trial. Over 2,000 patients of heart failure with NYHA 2 to 4 to LVF less than 40% and who had SE inhibitors intolerant. In those patients, candesartan 2 to 8 mg per day titrated to a maximum dose of 32 mg per day was tried. And after a mean follow-up of around uh, 34 months, it was shown that there was significant reduction in the combined CV mortality and heart failure hospitalization. However, the decrease in CV mortality itself was there was a decrease in CV mortality, but it was non-significant. Next slide. So apart from its use in HFrEF patients, SE inhibitors have been also tried in post-MI condition, and there have been 2-3 trials, important trials, which have shown that in post-MI patients with LV dysfunction, there is definitely mortality benefit if you can start SE inhibitors quite early in the course. So next slide. Next slide. So some of these trials like AIRE trial, around 2000 patients with AMI and heart failure, NYHA 2 to 3, Ranpil 2.5 to 5 twice daily, showed lower mortality at the end of 15 months and also at the end of 59 months. Similarly, TRACE trial with around 1700 patients, MI 2 to 6 days old with LVF less than 35%, Rondalapil 1 mg per day showed lower mortality, lower CV death, and lower progression to severe heart failure. In SAVE trial with around 2200 patients, 3 to 6 days old MI and LVF of less than 40%, but no overt heart failure. Captopril in titrated doses showed lower death, lower fatal as well as non-fatal CV events and heart failure hospitalization after a period of 42 months. So all these trials have helped us to use SE inhibitors in various molecules after in post-MI situation, after the initial stabilization, up to a period of say 3 years we can use, and they have been shown to give mortality as well as CV event benefit. Next slide. Now comes the different trials using beta blockers. So initially, in decompensated patients, some smaller studies and case series showed adverse events with the use of beta blockers. However, if we use beta blockers after the initial stabilization and when euvolemia is reached after the initial therapy with diuretics, there have been several trials which have actually proven the importance of beta blockers and the survival benefit as well as decrease in heart failure hospitalization have been proven quite well over the last 2-3 decades with the use of beta blockers, especially in HFrEF patients. So if we look at the different trials, 3-4 trials, like US carvedilol trial, it was a relatively smaller trial with around 1000 patients with mild to moderate heart failure severity, where carvedilol titrated to a dose of around 50 twice daily and followed up for 40 around mm, 6.5 months. It was a short trial, showed massive mortality benefit of a relative risk reduction of around 65%. Since it was a short trial with a lesser number of patients, so its mention has is not so much as the other trials which I am going to discuss, like for say the CBIS trial, CBIS 2 trial with bisoprolol with 2600 patients which were followed up for 1.3 years, where bisoprolol 10 mg per day uh, showed significant mortality benefit. Reduction in mortality, overall mortality was 34%, and also the all-cause hospitalization could be reduced by 20% on top of the standard therapy which were given at that time. So this trial came at around 99. Similar in the similar period, another trial like Merit HF trial came with metoprolol extended release in mild to moderate heart failure, around 4000 patients, where metoprolol was titrated up to a maximum dose of 200 per day, 200 mg per day, and it also showed a mortality reduction of to the tune of around 34%, and a hospitalization rate reduction of around 18%. Similarly, Copernicus trial, which came in around 2001 with carvedilol in severe heart failure patients, with around 2,300 patients. After a follow-up of 10.4 months, it showed a benefit of mortality reduction of 35% and heart failure hospitalization reduction of 20%. So only base trial with bucindolol, where a large population of large proportion of patients were of the black race, uh, could not show the desired benefit, which were shown by the other trials with beta blocker. So one of the reasons may be due to the population, which was largely consisted of black people, and also the intrinsic sympathomimetic property of the drug bucindolol. And obviously, over the last few decades, bisoprolol, metoprolol, and carvedilol have emerged as the main three beta blockers which are being used and recommended for the treatment of heart failure with reduced ejection fraction. In CV's 3 trial, it was they tried to show whether initiation of a beta blocker before AC inhibitor could be more beneficial. However, the results were not in favor of initiating beta blocker like bisoprolol earlier than AC inhibitor. So till date, no definite uh, uh, indication of starting beta blocker before AC inhibitor is there. However, if the patient is having a low BP and has reached stabilization after the acute decomposition, and we want to give them the beta blocker and AC inhibitor, but the BP is not permitting to give AC inhibitor, we can start by giving a low dose of beta blocker, and then if the BP holds, we can add a AC inhibitor. Otherwise, as the AC inhibitors were the first to be stamped of having mortality benefit, so the guidelines initially suggested that AC inhibitors should be started first, followed by beta blocker. Next slide. Though there have been no head-to-head trials between the different beta blocker agents, in Comet trial, it was actually an unfair comparison between carvedilol twice daily and metoprolol tartrate immediate release twice daily. So we know that metoprolol succinate, or the extended release formulation, actually gives protection over 24 hours. And in Merit HF, it was tried, and it has shown a great result of reducing the mortality. However, when metoprolol tartrate was uh, tried against carvedilol, lower mortality was shown in the carvedilol group in over 3,000 patients with heart failure of mostly NYHA to 2 to 3 class. Uh, so the formulation and the agent used was criticized, and so we cannot take the message seriously that there is actually a definite difference between carvedilol and metoprolol in HFrEF management. Next slide. So despite an initial and transient decrease in contractility, the beta blockers, the beneficial effects of beta blockers may be due to a variety of reasons. Uh, and those have been listed in this slide. I will just quickly mention that they can reduce the harmful effects of excessive and continuous increased adrenergic drive on myocardium, time-dependent improvement in ventricular structure and function, and improve the contractility of viable but hibernating myocardium, especially in the ischemic set of patients, reduction in atrial and ventricular arrhythmias, inhibition of the renin-angiotensin system, reduction in heart rate and blood pressure, and also beta blockers have anti-ischemic effects, including beneficial effects on the microcirculation. Next slide. So the digoxin, which was one of the mainstay of management of heart failure, congestive heart failure in the 70s and till the mid 80s, when it was tried in a strict RCT, which came up in the year around 1997, Actually, it failed to show actual reduction in mortality. However, significant reduction in symptoms and heart failure hospitalization could be achieved when compared to placebo. Next slide. Next came the mineralocorticoid receptor antagonists. So first came spironolactone in the DALES trial. Around 1600 patients with severe heart failure, mostly in NOHA class 4 with EF 35 or less, on treatment with SC inhibitor, loop diuretics, and in most cases digoxin. 25 milligram of spironolactone was tested against placebo. After a mean follow-up of 2 years, the primary endpoint of death from all cause was significantly lower in the spironolactone group. Next slide. Next came the alternate to spironolactone, which was often associated with the complications, side effects like gynecomastia and hyperkalemia, especially when used in combination with AC. So next came eplerenone, in which the incidence of gynecomastia was significantly reduced. And in heart failure patients, around over 6,600 MI patients with LVF of less than 40% with heart failure. It was started after 3 to 14 days of the MI, and eplerenone of 25 to 50 mg in addition to standard therapy after a follow-up of 16 months showed lower mortality, CV death, and hospitalization over a period of 16 months. And the gynecomastia was less compared to spironolactone. Emphasis high heart failure trial with around 2,700 heart failure patients, NYHA class 2 and EF less than 35, eplerenone 50 mg per day when added to standard therapy showed lower overall death plus hospitalization, and CV death as well. So this actually stamped the benefit of MRAs in the management of HFrEF patients, and as we all know, MRAs have also become one of the pillars of management of HFrEF patients over the last few years. Next slide. So if we look at the magnitude of benefit demonstrated in the few RCTs which we have come across, so if we look at the relative risk reduction in mortality, the SEs and or ARBs have shown to decrease the mortality by 17%, and number needed to treat for mortality reduction is around 26. Whereas beta blockers in the various trials have shown a relative risk reduction in mortality of 34%, whereas aldosterone antagonists have shown relative reduction of around 30%. And hydrogen nitrate had shown 43%, but in those days, the studies included a small number of patients and the other agents had not come up. And on head-to-head comparison, we have shown that ACs have been proven to be better than hydrogen nitrate combination. Next slide. Next slide, please. So some newer agents came in patients who continued to have increased heart rate of more than 70, and on a maximized or stable dose of beta blocker, or in whom we cannot give beta blockers due to the different contraindications. So one such agent was ivabradine, and it was tried in the SHIFT trial in over 6,500 patients with NYHA class 2 to 4 heart failure and LVF less than 35%, resting heart rate more than 70, and heart failure hospitalization within the last year. So it showed that the combined combined primary outcome of death from heart failure and heart failure hospitalization was significantly reduced with the addition of ivabradine on top of a maximally tolerated beta blocker, or in those patients in whom a beta blocker could not be given. So and this has helped ivabradine to get a class 2 indication in the management of HFrEF patients. Next slide. So in 2014, one of the very important trials which have come up over the last decade or so, the paradigm heart failure trial came up, So it included heart failure patients with LVF less than 35%. Later on, less than EF less than 40% patients were also included in NYHA class 2 to 4 with elevated natriuretic peptide levels. And in those patients, besides the standard therapy with beta blocker and diuretics, sacubitril valsartan combination was tested against enalapril, which was a age-old proven therapy by that time. So the primary endpoints was a composite of CV death or heart failure hospitalization, and the study was actually terminated prematurely as a significant reduction in primary endpoint could be seen in the sacubitril valsartan group. So number needed to prevent one primary event was 21, and one CV death was 32, which is quite low. And it went on to show the effectiveness of ARNI, that is sacubitril valsartan, on top of the standard therapy. So by that time, the different agents having which had proven mortality benefit like beta blockers and MRS were quite commonly used in heart failure patients. And on top of that, if we can add ARNI, actually it showed that it had incremental benefit. Benefit was more when compared to enalapril in patients of symptomatic heart failure with reduced ejection fraction. Pioneer heart failure study with sacubitril valsartan LVF less than 40% and increased NP levels, and who had been hospitalized for acute decompensated heart failure. So they actually tried to show whether first of all ARNI was safe in those patients and whether reduction in NT-proBNP levels could be achieved and whether future heart failure rehospitalization could be reduced. So the endpoints were met. ARNI in acutely ill patients, and it went on to show the safety of ARNI in acutely if when given to acutely ill patients, obviously after the initial stabilization with diuretics. Next slide. So over the 2-3 years,
বাসব একটু ব্রিফলি বল, এরপরে ডিসকাশনের সময় থাকবে না।
Okay. So SGLT2 inhibitors have come up with a bang over the last few years. There have been several trials in diabetic patients with high CV risk with the different SGLT2 inhibitors. However, since we are talking about HFrEF, I will focus on the two trials which have included HFrEF patients. So DAPA-HF trials, 4,744 symptomatic HFrEF patients with increased NT-proBNP levels, dapagliflozin on top of the standard heart failure therapy, dapagliflozin 10 mg daily versus placebo was tried after 18 months of follow-up, and it included both diabetes and non-diabetes patients. Diabetes percentage was only 42. So the primary outcome, which combined CV death, heart failure hospitalization, and urgent heart failure visit, actually was significantly less in the dapagliflozin group. And if we look closely, the percentage of patients who received the different heart failure agents like SE and ARNI was being used in over 90% of the patients. Beta blocker was used in 96% of the patients. MRS over 70% of the patients. So on top of the established standard heart failure therapy, if we can add SGLT2 inhibitors, it has been shown to actually have incremental benefit on top of the benefit provided by the standard heart failure therapy. And the benefit goes on beyond the scope of diabetic patients. That means in non-diabetic patients also, the combined endpoint could be reduced. And all-cause death actually was also lower in the DAPA group with a nominal p-value. Next slide. The EMPEROR reduced trial with empagliflozin, a similar molecule, in 3,700 patients with class 2 to 4 heart failure, EF less than 40%, um, empagliflozin 10 mg versus placebo was tried in addition to recommended therapy of heart failure. After 16 months, there was significant reduction in primary composite outcome of CV death or hospitalization for heart failure. And also the decline in GFR was slowed down by empagliflozin compared to placebo. CV death reduction by 8% was achieved, which is a bit lower than that achieved by dapagliflozin in the DAPA-HF. However, this trial actually included more serious patients with lower EF and higher anti-proBNP values. The investigators have used this data uh, in their defense. And also, if you can look at the older trials like EMPADEG outcome, actually that was the first trial with SGLT2 inhibitor to show mortality benefit in diabetic patients with high CV risk, whereas declared TIMI with DAPA could not show that mortality benefit. So whether DAPA is better or empagliflozin is better in mortality, in decreasing mortality, I think it is a still matter of debate, and I don't think any head-to-head trial will come up in the future for obvious reasons. Next slide. Newer trial, Victoria trial with CGMP analog vericiguat. It showed in HFrEF patients uh, on guideline-based HFrEF therapy with worsening event in the recent past. The combined composite endpoint of CV death and hospitalization, heart failure hospitalization could be reduced with the addition of vericiguat. However, mortality benefit or CV death benefit was not significant. Next slide. So I will skip this slide. This actually shows the different starting and target doses of the agents based on the different trials which we have already discussed. It is important to bear in mind that not only initiation but regular follow-up and trying to increase the doses to reach the target dose or actually achieve a maximally tolerated dose of the different agents which have shown survival benefit like AC, ARNI, beta blockers, MRA is very important to provide the maximal benefit we can give to the HFrEF patients who anyhow have a poor outcome in the near future. When I have a chance of CV event is always there. So if you want to give maximum benefit, we should up titrate the dose uh, to the best possible way. Next slide. So if we look at the 2016 ESC guideline, it was clearly written that in patients with symptomatic HFrEF, after initial stabilization with diuretics and euvolemia and congestion is relieved, so we should start with SE and a beta blocker. So they have not had not mentioned whether to use SE first or beta blocker. SE and beta blockers should be first given. If then still symptomatic, after say 2 to 3 weeks, 2 to 4 weeks, somewhere it is written, then we should go to the next agent, that is MRA. And if still symptomatic, then we should look at the different options, added options, like we can replace the SE with the ARNI. If the heart rate is not controlled, we can look for we can go for ivabradine on a maximally tolerated beta blocker, or in whom beta blocker is not tolerated. I will not go into the device therapy aspect. It will further prolong the discussion. I would only restrict to the pharmacological agent. So this was the more or less scheme of the sequence of addition of the different agents suggested by ESC in 2016. Next slide. Now, if we look at the recent 2021 guidelines of ESC, actually they have blurred the sequential addition of the agents, and they have said that to reduce mortality for all patients, four drugs, the four pillars are very important, have become very important, and those are AC or ARNI, beta blocker, MRA, SGLT2 inhibitors. Now, if we look at the look into the text which they have provided, still they consider that ARNI as a replacement of AC as a class 1 indication. However, they have also said that ARNI can be initiated in AC naive patients if the hemodynamics are permitting. However, that is not a class 1 indication. I think, if I can remember, that is a class 2B indication. Initiation of ARNI in a SC naive patient. Beta blocker and MRA indications are like that before in 2016. However, the SGLT2 inhibitors, which was not mentioned in the scheme of things in 2016, has come up strongly and has gained a class 1 indication. Regarding the sequence of addition, I still think, though they have not clearly mentioned, like they did in 2016, they have not this time clearly mentioned such a sequence of addition of the different agents. However, after reading the test, what I have gathered is that still they prefer SC and beta blocker as the initiating agents. Then MRAs and SGLT2 may be added if given a few given some time gap between the addition of the different agents. And then the other agent, the device therapies and the role of digoxin and especially in AF patients have continued to have a class 2B indication. And Vericiguat have received a class 2B indication. So next slide, we can quickly look at the levels of recommendation and the class of recommendation of the different agents. Next slide. Yes. So SC inhibitors in HFrEF patients to reduce the risk of HF hospitalization and death, class 1. Beta blocker, similarly class 1. MRAs, similarly class 1. Dapagliflozin or empagliflozin has gained a class 1 indication. Sacubitril valsartan is recommended as a replacement of for an SC in patients with HFrEF to reduce the heart failure hospitalization and death as a class 1. Next slide. So loop diuretics in HFrEF patients with signs and symptoms of congestions to alleviate heart failure symptoms and improve exercise capacity and hospitalization, class 1. ARBs to reduce the risk of heart failure, hospitalization and severe death in symptomatic patients only when they are unable to tolerate ST or ARNI. Ivabradine class 2A indication, like before, as we have already discussed. Vericiguat soluble CGMP stimulator, class 2B indication in patients having recurrent and worsening heart failure. Hydralazine isosorbide dinitrate, class 2A indication, which was previously class 2B indication in patients especially in black patients with LVF less than 35, EF less than 45 with dilated ventricle and severe symptoms, despite a treatment with SC or ARNI and the other agents which have class 1 indication. And in HFrEF patients symptomatic who cannot tolerate an SC or ARB or ARNI, hydralazine or isosorbide dinitrate may be tried as a class 2B indication. Digoxin, like before, it still holds a class 2B indication in patients with sinus rhythm. However, in AF patients, their role is a bit more and a stronger recommendation is there. Next slide. Discussion. I want to say that in the recent paper which have come up in the later half at the end of 2020 by John McMurray and Milton Packard, how should we sequence the treatments for heart failure patients with reduced ejection fraction? Next slide. So why did they come up with this new sequence of treatment? So what was the drawback of the previous sequence suggested by the ESC or the SEC? Next slide. Next. Yeah. So the drawbacks of the existing concept is that the existing concept is assuming that most effective treatment were developed first, which is not at all the case. So that is why SE first, then beta blockers, then MRA, this concept has come up. So it is not necessary that the sequence of discovery or invention shows us which is the better molecule. Next, the benefits to reduce morbidity and mortality can be achieved at a lower dose of the drug as well. So it is like that we should start at a lower dose, then titrate to a maximally tolerated dose of one agent, then bring in the second agent. It is actually not like that. And most patients in clinical trials were actually receiving sub-target doses of the recommended treatment. Not all patients were receiving metoprolol 200 mg per day or bisoprolol 10 mg per day in the trials which have been recently conducted. And in those patients also, which we have shown, we have seen that there is significant benefit with the newer agents. That means the newer agents can be added when the previous agents are being used, but at a lower dose as well. It is not necessary that we should increase the dose of the older agent before addition of the before adding the newer agent. A substantial proportion of patients in most recently completed trials were not receiving MRAs or RNU. We can see the DAPA-HF trial, 70% of the patients were on MRA. So the remaining 30% were actually not on MRA. And if they have looked at those group of patients as well, in those patients as well, there have been significant benefit with the addition of SGLT2 inhibitors. And if you look practically, when patients come with HFrEF, we don't know, despite our best efforts, how much months or years we can give the patients to live for. So if it takes several months to prescribe all recommended treatments in sequential steps, actually we actually may miss or fail to give benefit of a good molecule to the patient, and actually before addition of that molecule, patient may succumb. So this delay is unacceptable since each drug class can reduce morbidity and mortality within 30 days. The benefit actually starts as early as 30 days. Next slide. So John McMurray and Milton Packer have proposed a new algorithm to achieve treatment with all the 4 foundational treatments for euvolemic HFrEF patients after diuretic therapy, and all these agents can be started within 4 weeks, and then we can see that whether it can, and it is hypothesized to give better results and greater survival benefit. So the step 1 is simultaneous initiation of a beta blocker and an SGLT2 inhibitors. Both these agents have minimum hypotensive quality, especially SGLT2 inhibitor, and can be added in borderline hemodynamics as well. Then step 2, addition of sacubitril valsartan within 1 to 2 weeks of step 1. If SBP is less than 100, it may be prudent to first evaluate tolerance with an ARB before switching to RD. Step 3 is addition of an MRA within 1 to 2 weeks of step 2 if renal function is not severely impaired or serum potassium levels are normal. MRAs may also be initiated in step 2 in patients with troublesome hypertension. That means the patient is having low BP after beta blocker and SGLT2 inhibitors. After 1 to 2 weeks, we can add an
একটু
MRA.
বন্ধ থাকবা, আমার একটু কথা আছে এখানে।
আচ্ছা, ওকে।
Complete. Bashab, you complete.
Okay. So and up titration of targeted to target doses should be pursued after this period. After we have started the smaller doses of all the 4 agents which have shown to have survival benefit, then we can up titrate to the target doses over a longer period of time. At least we can give the benefit of all the agents together within a 4 weeks of diagnosis. After, obviously, patient is euvolemic. And caution is required in hospitalized patients with decompensated heart failure. Next slide. So the 5 principles based on which they have proposed this new algorithm is that magnitude of treatment benefit of each drug is independent of the other classes. So we should not deny the benefit of one drug and give and restrict the patient and deny the patient of the benefit of one drug when you are using the other. We can always try to give benefit of all the four drugs, as we do in, say, for example, in ACS patients. We give the benefit of antiplatelet as well as statin, as well as the anti-ischemic agents, as well as anticoagulation in the acute stages. Uh, Foundational drugs effective in reducing morbidity and mortality at low starting doses as well, which they have shown in trials with SE inhibitors and SGLT2 inhibitors especially. Addition of a new drug class yields greater benefit than uptitrating existing drug classes. Safety and tolerability can be improved by proper sequencing of drug classes. Much of the benefit of foundational treatments can be seen within 30 days. So we should try to incorporate all the four agents within 1 month. Therapy of yeah. So therapy, if we follow this sequence, we can start all four drug classes within 4 weeks. That is 1 month of stabilization. So I would like to end at this point and ask our seniors and colleagues what they think, and what is their preferred agent, what sequence they want to follow, and whether they are open to this new algorithm, and or where they should wait and for the new guidelines to come before jumping to this new algorithm.
Please unshare, Darshan.
And I need to leave for family commitment. May I give my comments before you go ahead?
You go ahead. Go ahead.
Firstly, there are two types of comments. It's not personal. Because it's in the, it will be in the Facebook and YouTube, and people will see it, the juniors will see it, and here a lot of doctors are here. From the position that I have given talks to different national and international fora and learned a lot over the last 35 years of my academic career, there are three things you consider while you are given a talk to deliver. Number one, the time. It is 6 minutes, it is 6 minutes. If it is 20 minutes, it's 20 minutes. If it is 40 minutes, it's 40 minutes. Every subject can be dealt with for 72 hours to 7 minutes, maybe 2 minutes. So you have to cut your talk according to the time allotted. There is no credit crossing the time. That is most important part. Number two is, what is the subject matter exactly given as a subject? Your subject was not the HFrEF management current status. It was HFrEF management, pharmacological management, the sequence of the drugs. Like say, if you have given the Indian independence movement, role of Netaji Subhash Chandra Bose, and if you talk 15 minutes on Sepoy mutiny and half an hour on Gandhiji, and talk 5 minutes on Netaji, that's not the justification for the subject. So that is most important. And third is, who is your audience? The same talk can be given to public forum, to IMA, general practitioner, to API, general physician, or to such elite group of cardiologists who are all DMs. So that is just for your future. I'm not criticizing you. I'm just saying how you should present a talk. That is for everybody's learning and for whoever is there. Second is the actual subject matter. I'll just raise a few points and then leave for you to discuss. Number one, if you see the most important change I have noted in the recent ESC, they have chucked out the ARB. It's completely gone. It's ACE inhibitor stroke ARNI. And it's absolutely justified, because the only role of ARB is when ACE inhibitor is not tolerated. That is due to cough. And if it's not tolerated due to cough, you have got ARNI. Accepting the money, so there is no scope of ARB in present day management of HFrEF. That is number one. Number two, which I still find very paradoxical, which is recently gone, very fortunately, that after RAS blockade and beta blocker, if the patient is still symptomatic, then you go for MRA, then you go for SGLT2. And on the left side panel, it is given that diuretic can be given at any stage to reduce the symptom. So if you adjust the diuretic, your patient does not remain symptomatic. So if you increase your Lasix, you perhaps have no patient who will require MRA or SGLT2 by the old algorithm. So that is very funny, and that was very paradoxical. If you see in the most recent guideline, symptom is not there. You have to give all the 4 medicines, because here you are not talking about symptom, you are talking about prognostic benefit. And very nicely, in the second line, even in green, that means class 1 indication, is diuretic is now class 1 indication and is given not only for morbidity, but in selected cases to improve mortality as well. So I think diuretic is revisited. That we should not forget, diuretic is revisited along with the 4 disease modifying agents. And I don't know the role of vericiguat. Maybe in renal failure patient, vericiguat will be good. It is yet to be seen. So that is my 2 comments on this. And you go ahead, I will take your leave.
Soumitra, one point is the subject was the evolution of the drugs. So the different trials, what Bashavendra has evaluated and enumerated, that is perhaps in the topic itself, because it was the evolution of the drugs. It is the second part was what is the sequence of drugs you should use. That is the second part of the story, but the first part is the evolution of the drug. It was a very big subject. He could have done a little shorter because the time allotted was 30 minutes. He has exceeded it by 10 minutes. But in this fora where the subjects, the slides are not being shown properly, that is another issue which is also taking some time. I think this can be accepted. And what you said is very correct. Second part, you need to use all the drugs. In fact, I just be here for 5 minutes. The drugs we use for HFrEF patients, if the patient is hemodynamically stable with a significant LV dysfunction, say between 35 to 40, don't you try to give all the drugs together? That is all of us do in small doses. So the sequence of drugs start with a AC inhibitor, then add up a beta blocker has gone for a long time. None of us use it. None of us use it. We all start at least the 3 drugs: AC inhibitor, beta blocker, and MRA in small doses in all the patients with HFrEF. And as you have said that if the volume status can be optimized in the by monitoring about modulating the diuretics, we all use these 3 drugs. What is not in our pen habit is the use of SGLT2 inhibitors from the very beginning. And what is the role of SGLT2 inhibitor vis-a-vis diuretics, because they also have a diuretic effect. So what will happen to the dose of the loop diuretics we use? So this is the only thing which is not in our pen habit, but I strongly believe this will also come in very shortly, and we will be starting with all the 4 drugs together if the patient is having an optimum renal function and is not desperately symptomatic with a good BP. Comment?
Exactly. I really enjoyed the talk. What I was telling to make it a bit streamlined so that
that is perfect. Whatever
traction.
guideline you have given, I think we should
if
follow.
Bashavendra permits, I will have a set of that slides also, because it's a very comprehensive slides. You can use it in various forums because it is very comprehensive.
You can use these different
if Bashavendra allows, I will have that slide set as well. Very well compiled slides.
You will send it. And questions now. 5 minutes thak na. Soumitra, be here for 5 minutes. Sorry, I'm telling Bengali again. Let everybody be here. Any question? Shodo, comment?
I think I want to make one comment, because long time back in 1986, you had the first trial with vasodilator, the VHF trial, a combination of hydralazine and isosorbide nitrate that shows a real sea of benefit. But post that, starting from 1987, you had these ACE inhibitor trials, after which the benefit of this combination was sort of eclipsed. But till now, the hydralazine and isosorbide nitrate combination does figure in the guidelines, both ESC and this ACC. But we physicians or cardiologists are a bit reluctant to use it, even in those cases in which the patient is resistant to all other treatments. And especially the beauty of this combination is it's a combination of a preload and afterload reducing agent. So before switching on to this SGLT2 inhibitors and ARNI in the vast population of have-nots, I think we should give a trial with this combination, whether the patient is a Black patient or not, because the AHEF trial, that was a dedicated trial in the Black patients, but that doesn't mean that this particular combination will not work out even in the non-Black patients. So I think that in patients, since it's still figuring in the guideline, even with a class 2A indication, one has to give a trial for these agents in patients who are still symptomatic after receiving the standard therapies. Secondly, the point that Shomitra had raised, maybe the Bashov's slide was a little bit extensive, but still this forum has got another endpoint that it will allow the speakers to develop a skill of talking so that in the future they might improve and might deliver a type of lecture so that they become attractive to their audiences.
Shauroda, this AHIF, I have given a lot of thought about it. Two or three things. Number one, as you said, it was in Blacks. And Blacks traditionally have low renin status in the body. So in the realm of RAS blockade, whether there will be incremental benefit of isosorbide dinitrate and hydralazine, that will never be known because it won't be done. In a high RAS blockade patient like Asians. Asians are high RAS patient. Number two is that if you see the p-value of AHF, it's astronomically fantastic, 0.0000 something. And that was some design problem, or I don't know what happened to that trial. That's why it was never very popular. And if you see, there was nothing in the background treatment at that time. So again, with the modern day treatment, what will be the role of thing, we do not know. But as you said very correctly, in Indian background with lot of so poor people, it is a fantastic option and we really underutilize it. We should see it when the patient can't afford an ACE inhibitor, can't afford an MR, even MR is so expensive, and the SGLT2 can't afford, we can always use it. And we see there must be benefit, that I believe, but we definitely underutilize. As Shantanu said, it's not in our pain, perhaps, gone from our pain habit.
Bashav, I'll just, regarding the last part of your slide, that is the recommendation by John McMurray and Milton Packer. What they suggested is start with an beta blocker and SGLT2 inhibitor. You then add up an ARNI. If the patient is hypotensive, in that case, you go ahead with an ARB. In their scheme of things, they are practically and totally eclipsing the AC inhibitors. You go through that guideline, that last part of the guideline, AC inhibitor is nowhere there.
No, are you sure?
Yeah, absolutely. Absolutely. If the patient is hypotensive, instead of using ARNI, you start with ARB. Am I correct, Bashav?
No, if patient is hypotensive, instead of ARNI, you can add a MRA.
No, that
ARB
is there.
Is not there. ARB has gone.
Can I have the last slide?
Yeah, ARB, they have actually said ARB instead of ST. Yeah. Not if hypotensive, but
this is extremely important because
let's clarify that. We have to know that.
Darshan, can you just again reshare the slide and go to the last but one slide?
This is
Second last
important.
slide. Yeah,
This
second
is
last
important.
Penultimate.
Yeah.
This one, no?
No, the
Just a
previous
minute.
one.
Before
The
that,
previous one.
the one, yeah, just here.
Simultaneous initiation of a beta blocker and SGLT2. Step 2, addition of ARNI within 1 to 2 weeks of step 1. If SBP is below 100, it may be prudent to first evaluate tolerance with an ARB before switching to ARNI. Third is addition of AMRA within 1 to 2 weeks of step 2 if renal function is not severely compromised. You are totally eliminating AC inhibitor, which
That's a
I
bit
find
strange. Are you
which I
sure,
find is
Bashutta,
not
you have
acceptable.
put it rightly from the text?
Yes, sir. I have looked into the paper. I have directly taken up from that paper only.
Shantanu, you have pointed out very nicely. I never noted it.
I mean, I just could see this part because please take off the share.
Whereas in the
Please off
ESC
share it.
guideline, ARB is totally out.
Yeah, please don't take off this slide sharing.
That is very strange. Very, very strange. And we have to
That
see
is
what is the reason.
a very important thing. That is simply because in the ESC's guidelines, still now, you start with AC inhibitor, beta blocker, add up MRA, even you can start simultaneously with MRA and nowadays perhaps with SGLT2 inhibitors. If patient is symptomatic, go to replace AC inhibitor by ARNI. That is the scheme of things of ESC. That is simply because in many patients, if you give this 4 drugs or first three drugs, NT-proBNP level comes down, patient symptomatically improves, and you don't have any clinical evidence of heart failure other than a diminished ejection fraction, which takes time to improve. But if you that means even with AC inhibitor in a large number of patients, we can normalize the NT-proBNP, and that is one trial where they have recommended you titrate your treatment based on the NT-proBNP.
Yeah.
You know that. So
Yeah.
if that is the thing, if it is normalized, why should I up titrate it to a costlier drug, particularly in the Indian perspective? And that AC inhibitor has been totally disregarded. This is one thing I find it a little difficult to accept. Any comments from anybody?
No, it's very true. It's very true.
Actually, Shantanu, I know maybe it is a promotion from the industry or trialist, but they are pushing for the highest tolerated dose rather than being satisfied when NT-proBNP is normalized or you don't have symptom. They are still trying to push the highest tolerated dose. I don't know whether
correct. Absolutely correct. That is another scheme of things. If we hardly have any data on that. If the NT-proBNP has normalized,
true,
patient is asymptomatic,
I don't know
how much we benefit
how much is commercial,
how much is
commercial, I don't know.
I don't know.
I do not know. Basu, you tell me one thing. Do you have any preference for DAPA versus EMPA as a group or in dilated cardiomyopathy vis-a-vis ischemic cardiomyopathy?
From my personal experience, I have used dapagliflozin last few months more than empagliflozin. Some points are there, though I don't have personally any preference over dapagliflozin for dapagliflozin. Initially, the cost was one of the reasons, wherein the DAPA molecules came in at a lower cost. I could give dapagliflozin to a lot more patients, which I could not give empagliflozin before that.
Sure, we were considering the economic aspect, which is extremely important for us. I agree. Is there any reason in Emperor reduced? What was the survival benefit? Vis-a-vis in DAPA heart failure, what was the survival benefit?
Survival benefit of DAPA in DAPA HF was greater.
Yeah,
If we look at only mortality, yeah,
Yeah.
in
yes.
DAPA itself, mortality
That is the
benefit was
answer. So
Yeah, absolutely.
DAPA perhaps we'll use more.
Yeah. Only thing is that when in ischemic background, there is a preference of EMPA. But now the question comes, if it is a die down ischemia, it's an old ischemia, it's now ischemic cardiomyopathy, and there is no active ischemia going on, either symptomatically, ECG changes and so on. Then what takes predominance, ischemic part or heart failure part? And it is very well known that heart failure is a far bigger killer than ischemia. So here I would say, to me, by analogy, I would still prefer DAPA, even in ischemic cardiomyopathy, even if there is no active ischemia going on. If there is evidence of active ischemia, maybe I'll be tilted to EMPA. That is my personal view.
Unfortunately, there is no robust data or any head-to-head comparison. So we have to go by our personal opinion. Can't help it.
Yes.
By any of my past students, any
Spondan
comment?
was going to say something. Spandanda.
Now,
Spandan, yes.
yes, regarding this DAPA-EMPA discussion, the effect of these SGLT2 inhibitors on ASCVD endpoints are relatively heterogeneous, because in EMPA-REG, the ASCVD endpoints were much reduced than this declared TB. But this heart failure, regarding heart failure, this benefit, total benefit of hospitalization and mortality is equal, though the mortality benefit is more in DAPA heart failure study. And the basic difference between this emperor reduced and this DAPA heart failure is that the emperor reduced started earlier, so these patients recruited had lower EF at baseline. This is number one. And underlying drugs used in emperor reduced population, the percentage of ARNI was very meager. In DAPA heart failure, the mean ejection fraction was 2% more. The efficacy was equal, total efficacy. This is heart failure, hospitalization, and mortality taken together. And in this population, the total percentage of patients on background ARNI was much more, nearly 30%. For that reason, this would start all four together came after DAPA heart failure, that these, even with coexistence of best possible guideline-based therapy, that is ARNI, beta blocker, MRA, the DAPA heart failure provided added benefit, whether irrespective of presence of diabetes or not. For that reason, from that angle, and regarding this price benefit, at least I should prefer dapagliflozin in heart failure subpopulation,
Right.
irrespective of the ischemic or non-ischemic etiology.
Fine. Any other comment or thing? Bashobi, want to say something more?
Yeah, as rightly said.
Bashoba, you want to ask a question?
Yeah.
Actually, I want to ask whether what is your time of initiation of ARNI in acute heart failure hospitalized patients? Do you consider it just pre-discharge, or do you consider it after giving AC inhibitors and then? Or so your comment?
So in most of our patients, one thing we should look at is as the hemodynamics. What is the BP? Whether the patient can tolerate AC naive patient can tolerate ARNI or not, and whether they can afford it or not. We can always start a molecule, but we never know whether they will be able to continue it all the way. So if the BP is borderline, I am not confident, then I will give AC inhibitor first and titrate up the dose, and along with AC inhibitor, I will try to add simultaneously a beta blocker and MRA as well. And SGLT2, whether I should add at the same time this thing, I'm not too sure. Maybe I will take 1 week after the critical period is, or 1 or 2 weeks after the critical period is over. That is my personal experience. Arni, I will start in an SE in a naive patient only if the BP is permittable
More than
and say 110.
110.
Yeah, this is my personal experience. I am.
It is recommended should be above 100.
Yeah.
It should be a recommended book description is should be above 100.
Above 100, but
Yeah.
we never know. Our monitoring is not so stringent often. So
Quite true.
yeah.
Quite
So
true.
that is one thing, and whether they can continue affording that ARDNI when they go back home after the initial 2-3 weeks, whether they can afford it. That thing we should also look at, and whether they can monitor the renal profile and potassium on a regular basis. So all these things taken together, we should consider before choosing our RAS blockade of choice after the initial stabilization.
Any other question? Siddhartha, Prayank, Shotten, Kollan, Nita, Rajosh.
I wanted to ask that there is an increased incidence of urinary tract infection when we use SGLT2 inhibitors. So the patients high risk of UTI, like elderly, those who have obstructive urinary diseases, should we inhibitor, or we can start in that population also without screening for
Bashab.
Yeah, so if you ask me personally, I am always a bit apprehensive. I ask patients whether they are having any lower urinary tract infection before starting SGLT2 inhibitor. So I have found a few cases who have come up after say 2-3 weeks with lower urinary tract infection, and I had to withdraw the SGLT2 inhibitor after controlling of infection. Then in some of the patients I have not yet started, in some of them I have started with the advice of regular proper genital hygiene and adequate hydration, those things. So
Actually,
I can
Prayank,
give a tip. I can give a tip over here.
Yeah.
There will be zero genital infection if there is no sugar in the urine. So in a non-diabetic heart failure, you are fine. There will be no infection. In a diabetic heart failure, first control the sugar with glimepiride, gliclazide, or insulin, or whatever you like. And once the sugar is controlled below 200, then give dapagliflozin, empagliflozin. You won't have any sugar in the urine, and there will be no infection. So that I adopted this strategy, and I got benefit out of it. It is
actually, this is not an LRTI, rather it is a fungal infection is the most
Exactly.
frequent one.
Exactly.
Okay, that again depends on the local milieu of
Yeah, local
glucose.
sugar. Sugar
If
in
the sugar is less, that infection will be less.
Absolutely.
So that is one issue.
The second things are regarding AMPA versus dapagliflozin. Now dapagliflozin got FDA approval for this heart failure quite recently, while empagliflozin got that approval much more earlier than dapagliflozin. So we have a more aftermarket experience of empagliflozin versus dapagliflozin. So yeah, it may be a personal choice, but I always prefer empagliflozin.
You can use it. There is no head-to-head comparison. So both the drugs has been recommended by the ESC for the reduction of the heart failure and the treatment of heart failure. So you can use either. There is nothing wrong in it. It is more of a personal choice and the economics. What is more important?
Yes.
Siddhartha Somnath, I'm seeing his face. Till now, his video was blocked. Now you have opened it. Somnath, any question?
Soumitra.
সোমনাথ, আরে এটা কোথায় শোনে না, এত শোনা কথা শোনা যাচ্ছে না।
Unmute করো।
Okay, sorry. So, Soumitra sir, do you have any experience of urinary tract infection in particular age group of any patients or any gender bias like female patients? Because I have seen that for me, it is more prudent to avoid this drug, SGLT2 inhibitor, in around 30 to 50, 30 to 60-year-old female and who are working female. And I experienced these UTI in female patients mainly, and again in non-diabetic patients also, as the mechanism of SGLT2 inhibitor is glucosuric. So I think there may be a chance of urinary tract infection, genitourinary tract infection in these patient, non-diabetic patients also there. So it is my, it is an observation. I don't know, is there any
Fine.
data?
Anybody want to take that part? Soumitra, you are here. Then Spandan, do you want to come and say anything?
Actually, I agree with Somnath. It is at least better to write a urine routine examinations with special reference to parcel count before prescribing this, particularly in females.
Absolutely, sir. Absolutely.
That too in aged females and males who have some bit of obstructive bladder outlet obstruction in different forms. They have some latent infection, urinary tract infection, lower urinary tract infection. Prescribing SGLT2 inhibitors in those may convert a lower UTI to upper UTI, which is a much serious condition. And so what I do is at least write a urine routine examination with special reference to parcels. I write like that so that it is properly seen before going on to it.
Okay,
And
Rothin, you have a
the
question.
counseling.
And do you have any experience about the glucosuria in non-diabetic patients who are having prescribed SGLT2 inhibitors?
No, the mechanism is glucosuria. Mechanism of action, if a non-diabetic, what SGLT2 inhibitors do, they reduce the renal threshold of glucose.
Yes,
So,
absolutely.
So in postprandial state, even non-diabetic patient will have glucosuria.
Glucosuria, yes.
But the
So
So
quantum
the chance
should
of
be
infection
reduced.
will be
Yeah.
same in these
Yes.
patients.
No. The
The
more
chance
the
of infection
glucose,
will be more in diabetics.
the more the
Yes.
glucose excreted, more is the risk of
Yes,
infection.
yes. Chance of infection is yes. I definitely agree with that. Chance of infection is more in diabetes.
Rothin, you have any question? You have raised your hand.
This is I had one query regarding the if a patient who has started, who is on the four pillar drugs like beta blockers, ARB or whatever, if the patient is just starting having ascending potassium, so what should I relocate first? The ARB, this aldactone, but that's MRAs or the ARNIs, which comes earlier in case of reducing the dose or relating the drug at all.
Bashab, you take this question.
The patient is having ARNI and MRS, and he is having hyperkalemia, right?
Yeah, the not actually hyperkalemia. If the patient is landing with hyperkalemia, so we of course we will have to off both the category of drugs, that is RNs and MRs. But if we say that this is on the higher side of normal sense, so what should I this titrate first?
Acha, initiate. I think we can initiate ARNI at a low dose first before adding.
Not an initiation.
The patient is already on drugs.
Patient is already on all the four drugs, four foundational
Which one to
drugs.
address first?
Now it is, it has crossed 5 or 5.1, 5.2, perhaps he's meaning that thing.
Understand. Yeah. So I think we can first reduce the dose of MRA first and see whether the potassium is coming down or not. Then if still it is high, there are two options. We can stop the MRA for 1 or 2 weeks, and or we can reduce the dose of ARNI as well after reducing the dose of MRA. I think stopping MRS for 1 to 2 weeks will be a better option, because another thing is that concomitant beta blocker use is also very important and plays an important role behind the incidence of hyperkalemia. So that thing also we should keep in mind. So first we should decrease the dose of MRA, and then if still it persists, we can stop the MRA for 1 to 2 weeks. Then we should address the earning if it is still persistent, and lastly the beta blocker. And if we think that the heart rate is well controlled and the BP is on the higher side, and we don't want to stop the earning at any cost, then in some selected patients we can hold the beta blocker and see whether the things are improving. Because in
Beta
some
blockers
patients,
do not work very well in this. I theoretically what you said I understand, but they do not increase the potassium level that much clinically. So you have to choose between MRA and the earning. And
firstly, MRA
as
and
you have
earning.
rightly said, MRA should be targeted first.
But
It
I don't
should be-
think that there is any evidence-based approach here,
No,
because
no.
we have
These are
to
all
use your
personal
own
approach.
judgment.
You need to use your own judgment and nothing else.
Yeah, this is all.
What is an
answered.
interesting question, Ratin?
Very
Interesting.
good question. Good question. Any other question? We had a very long discussion,
Yes, sir.
and it is good. Bappa, I am not seeing his microphone. I am only seeing that his video is.
Yeah, many participants are silent.
Yeah, you need to speak out. You need to speak out, so that by the interaction we can improve our own knowledge. This is just for updating our own knowledge. If there is no further question, and is already we have exceeded the time by nearly 40 minutes, not a small quantum. We started late, but we have exceeded the time by nearly 40 minutes. One question before we conclude. Shomnath son, good.
Sir, I have to leave.
Yeah.
Just 1 2
You are
minutes.
excused.
সৌর স্যার স্পন্দন দা প্রায়ং দা
No, 2 minutes.
দারুণ
2
লাগলো
minutes.
অনেকদিন পরে দেখা
Hold on. Before we depart, one question: who is going to take up the next? Who will be the next speaker?
I think you can form an WhatsApp group between yourselves.
Now that is a WhatsApp group is there. It is named UCD Study Circle. You are also a member. Just look at your mobile phone. You'll
No,
find.
no, I know that. But these
So, it
juniors
is there,
may
but-
make a WhatsApp group.
But you can see the faces. This is better. Anybody who wants to be the next speaker?
You can choose your subject too if you want to.
Yeah. Shomnath appears little enthusiastic. One.
It is very difficult to come at 3.
So,
After Sachin Saurav's performance, it is very difficult.
no,
Either I
no,
have to be Virat
no. Now
Kohli
you
or...
are Rahul Dravid. Don't worry.
No, sir, I am not Rahul Dravid.
No, basically
So-
you spark off the debate, and basically it's the discussion which matters more than the
Yeah, it is a
speech
discussion.
itself.
This is a far better. By this you know. There are several questions I jotted down. I couldn't start. Bashav, you have mentioned about the consensus. You didn't mention about the consensus one. Consensus one actually let us know how to proceed in the trial. It increased the mortality. You gave enalapril in the acute post-MI scenario and killed a lot of patients. So these are the things which you should have mentioned. Not only Soumitra was little skeptical, but I wanted you to speak even more on these things. But little briefly you speak.
Yeah.
Because we know the history of all these things. These are extremely important. Extremely important. How did you get this consensus too? From after learning from the consensus one that active ingredient should not be given IV in post-MI patients, that is going to kill a lot of our patients. You started consensus too. So these are important. You need to know about all these things. Anyway, because of the lack of time, we could not complete all these things. But Shomnath is one speaker. The another speaker will be
Bappa. Bappa
Papa is
Supratim.
not available next day. Papa is not available. He's
Supratim
saying-
may be there.
Supratim,
স্যার
he
নেক্সট
will be-
ডেটটা বলুন,
Next
নেক্সট ডেটটা বলুন।
Couple of weeks later.
After 2 weeks.
আফটার 2 উইকস, তার মানে আমি কালকে জানিয়ে দিচ্ছি স্যার। আমি ফার্স্ট সানডে হলে হয়তো হয়ে যাবে, আমি বলে দেবো, আমি পারবো।
I don't know whether it is the first Sunday, but this is likely to be the first Sunday.
Yeah, it's the first Sunday.
It is the first
আমি
Sunday.
কালকে জানিয়ে দিচ্ছি।
It's the first Sunday.
So Shomnath and Supratim. Okay.
আমি কালকে জানিয়ে
I
দিচ্ছি।
will talk to you regarding the subjects. You can give me some options, and we will discuss and we'll finalize. So
ওকে,
thank you very much.
Thank you, thank
all
you.
of you
ভালো হলো।
for
Yes, sir.
this first
Thank you, sir.
session of the UCD Study Circle, and I could see Priyank after a long time.
Sir. Thank you, sir.
Nice.
He is badly
Nice,
missing the
Frank.
snacks, sir.
Huh?
He is badly missing the samosas.
Okay. Thank you very much, and good day. And thanks to the Anurag and everybody for nicely organizing this. Pulak, you are here. Pulak has left.
I think the transmission was excellent today.
Yeah, transmission was excellent. Everything was
Flawless.
very good. Everything was good. So, without spending any further time, because these organizers, they are getting little restive, because we have taken already 45 minutes extra. So let us call it a day. Thank you very much.
Thank you, sir.
We will be meeting after 2 weeks. I will post everything in the WhatsApp so that you just have a look there and you'll find it. Bye bye. Bye bye.
Thank you, sir.
Bye.